Response in Governor Mills' office. I welcome you this morning to our monthly opioid response webinar. Today we are covering the subject of our overdose experiences, both fatal and non-fatal, in 2022. Many of you are aware now that those numbers in that monthly report for December, which contained the aggregate data for the year, was posted on the mainedrugdata.org website yesterday afternoon. So you've seen some of this in the media, and this hour gives us an opportunity to share with you a deeper dive into those numbers. And we're very fortunate today to have with us Rebecca Taylor, the Deputy Director for Research and Evaluation at the Office of Behavioral Health, which is within the Department of Health and Human Services. Rebecca has a medical background and also a research and data background, and co-chairs with me the opioid data sharing committee that meets every month and brings people around the table who have pieces of our opioid data around the state. She is joined by Dr. Marcella Sorg. Dr. Sorg is a forensic anthropologist with the Margaret J. Smith Policy Center at the University of Maine in Orono, which is the University of Maine. Dr. Sorg also has a medical background and was trained as a nurse and practiced as a nurse for 7 years before going back to school and getting her PhD. And we're very fortunate that for many years, through an arrangement with the Office of the Chief Medical Examiner, that she and her team work with this information and each week and provide us with this data. Couldn't have two better people with us this morning to take you through that information. I also want to introduce Madison Barassa, who is our SUD program manager at the Office of Behavioral Health, and she's also in that position, taken on the work of what used to be done by our project managers working closely with me. And we've appreciated Madison helping us get these webinars together. Before I forget it, I will remind you that we do have our next webinar will be March 3rd. And we have been promised to have a federal official present that day. I've asked someone from SAMHSA or ONDCP, probably from SAMHSA, will talk about the provisions in the Consolidated Appropriations Act signed by President Biden in late December. That law, as many of you know, incorporated into it the Mainstream Addiction Act and many of the provisions that we've been trying to work on for years, such as getting rid of the ex-waiver process for people prescribing buprenorphine. So I really was anxious to have somebody from the federal government tell us what's in that bill, because it's 4,000 pages long, as I recall, and its significance in their view, what rulemaking might not need to take place now to implement any of it, and also to talk about the enhanced appropriations that were given in the various buckets that SAMHSA gets and what that might mean for us here in Maine. So I hope the presenter will be our friend Tom Kadir, the Deputy Assistant Administrator, but if not, Tom will ensure that we have a knowledgeable person. I'll make just a couple comments here about yesterday's report. I remind you that it's on the mainedrugdata.org website, where we always place a monthly report. The total fatalities for the year was 716. That's a 13.5% increase from what it was a year ago. That is less than the 25% increase we saw the year before, but it's still 85 people. It means that 85 more people, Mainers, died last year than the previous year. It's a very high number. It's not a number that we're happy with. but we also, you know, very much have to think about the 9,391 individuals who survived their overdose in 2022. So that the fatal overdoses as a percentage of all the overdoses is still remains about 7%. How do we do that? Well, we try to connect with those individuals. And I remind you that that's not necessarily 9,391 distinct individuals. That might be 3,000 individuals, each of whom overdosed 3 times. I remind you too that these overdose numbers are absolutely lower than the actual numbers, because there are many private saves, if you will. We are trying to saturate our communities with Narcan. We encourage people to be revived at home with Narcan, and we may never learn about that incident unless 911 is called. You know, we now report on them when we know about them through our naloxone distribution initiative, but we know that we don't know of every overdose where there's a save. The other things that we're doing, we just this morning had another meeting of our Overdose Review Panel, and I think it will please our attendees this morning to know that there's an expert group of 15 people, physicians, researchers, law enforcement, that get together every month or every other month and do a deep dive into one or more of these cases. We've had 8 meetings now. It's a statutory group, because we have to do our work confidentially if we're going to be able to get all the records from the jails, the treatment facilities, the mental health facilities. But we are able to construct, it's a lot of work, but we are able to basically write the story of this individual's life. Died of an overdose at age 39, but we are able to go back and say, what was this life like as a child? Who were his parents? Were they, how long did they live? Did they lose custody of that child? Were they using themselves? And we make recommendations based upon what we learn in the course of writing those stories. So naloxone distribution, our overdose review panel, and then finally, but not the least initiative, is our options liaisons, who we have in every county. We'd like to have more. We think that we have good data from them to show how many referrals they're making. The job of our behavioral health liaisons that are hired through 5 different behavioral health firms in the state, their job is to reach out to people who have survived an overdose. Our entrees may be rejected. We may not be able to get confidential information to allow us to locate an individual, but we do the best we can to try to reach out to these individuals. And not just, I mean, we're not limited to that group, but anybody that we can find that will interact with us and connect them to something. Harm reduction, treatment, recovery center, something that connects that person, because we know if we don't, then there's just too much chance that they will end up on the other side of that ledger and be one of our fatal overdoses. We know what percentage of our fatal overdoses are people who have previously overdosed. And while our numbers actually don't yet reach 50%, I suspect they are, but we're only able to confirm maybe that 30 or 40% had one or more overdoses prior to. And we're really working hard to make sure that that our healthcare system and our law enforcement community and our treatment community are not missing opportunities to connect with people before that overdose. Were they just admitted? Had they been in the hospital recently? Had they been in the jail recently? Had they been to a medical provider recently? And if they died within hours or days of those visits, was there an opportunity missed? We don't mean to point fingers. We just want to make the system better for people. So with that fairly lengthy introduction, I'm going to again turn this over to Rebecca and Dr. Sorg. And the only other thing to announce is please put your questions in the question and answer box, not necessarily the chat room where everybody can see it and comment on it. Put it in the question and answer piece, and we will answer some during the webinar. We don't anticipate, there are over 550 people that registered for this Zoom, which is fantastic because it shows that people are interested in this information. We don't anticipate getting through all the questions. Put them in the question and answer thing, and we will answer all of them in writing, put the answers on the AdCare website where all our documents exist. So with that, Rebecca, I know you've got the first slide. We'll let you bring up those slides and I'll just monitor the questions. Thank you for everybody for being with us this morning.
Thank you so much, Gordon, for that introduction. And thank you for the opportunity to talk about this very important topic this morning. Hi, my name is Rebecca Taylor. I work with the Office of Behavioral Health, and I feel very privileged and fortunate to be here today presenting with Dr. Marcella Sorg, who is a bit of a professional hero of mine and has done such amazing work on this subject for many a long year here in Maine. So just a brief overview of what we'll be talking about this morning. We know that the primary reason that you are all here today is to hear about what our last year's overdose data show. You probably want to know what we think the explanations are for why we continue to see an increase in overdoses, both fatal and non-fatal in our state. And you probably want to know what the state is doing about these statistics. So that's what we'll be covering this morning. First of all, just to level set a bit, as Gordon mentioned, Marcy and I both come from a medical background, and to a member of the lay public, it might seem like a very straightforward thing to identify a person who's experiencing an overdose, but it's actually a little bit more complicated than it might appear at first glance. An overdose is a medical emergency, and specifically an opioid overdose involves a person's respiratory drive, the brain function that tells you to breathe, being slowed down or even stopped entirely. The person who's experiencing an opioid overdose has no control over this happening. They're usually unconscious or at least unaware of their surroundings, and they need help from others, CPR, Narcan or naloxone administration, in order to survive the effects of the intoxication from opioids. And it's unfortunate but true that even when people are revived from an opioid overdose, often the case is that the oxygen deficiency that has happened in their brain has caused long-term damage. So a person may be revived from an overdose, but sustain long-term or at least short-term trauma to their brain and other organs due to that oxygen deficiency. Now, why is it complicated? That seems straightforward, right? Well, often folks who experience an overdose also have other substances in their system that may complicate the presentation to first responders, EMS, clinicians, and law enforcement professionals who arrive first on the scene of an overdose. May not know right at first what is happening for sure, particularly if the person is alone and there's no one around to explain what has been occurring at the scene. So just to level set a bit, almost all, nearly 80% of the folks who experience a fatal overdose in Maine have 3 or more substances in their bloodstream at the time of the overdose incident. And more so, we're seeing co-intoxication with stimulants and even xylazine, which is a veterinary tranquilizer. So we'll talk more about that in a moment, but just to set the stage a bit, that it's often not clear to these first responders whether the person is having an overdose, they might be having a stroke, they might be having a heart attack, they might be unconscious for a different reason. And typically, first responders don't have a way, even if there are drugs found on the scene, to determine what is in those particular substances. They may have clues based on the paraphernalia, the equipment that's at the scene, but really what is the proxy for identifying an opioid overdose is if a person responds positively to Narcan. So if naloxone is administered, and I apologize, I switch back and forth between Narcan and naloxone, but they are the same overdose reversal medication. One is the trade name and one is the generic name. So if an individual responds positively when naloxone is administered in that they recover consciousness and their breathing rate increases or resumes on its own, then the clinician will assume, okay, this was an overdose involving at least an opioid, potentially other substances. So I just wanted to add that context because the complexity of identifying an overdose in our data in the field is part of the reason why it is so difficult for us to precisely and accurately track non-fatal and fatal overdoses. Fatal, we can, do lab testing and receive toxicology results, but the non-fatal overdoses that are seen by EMS clinicians, law enforcement, or community responders, those are harder to really define with precision because it's not clear at the time what the substances are that are involved. So as Gordon mentioned earlier, we actually have thousands of overdoses in Maine that occur every month. Most of those are non-fatal overdoses. Most of those incidents result in a person still being alive once they're revived. We do have a total of about 10,000 overdoses per year in Maine, which seems like a shocking number, and it is. And as Gordon mentioned earlier, it can be the case, and in fact often is the case, that individuals may experience more than one overdose in the course of a calendar year, or even in the course of a given month. But again, as I said, only about 7% of those overdose incidents result in a fatality. So 93% of the time, when people have a person with them at the scene of an overdose, or if EMS or law enforcement or other first responders are able to present before the person is in fact deceased, they can be revived by Narcan and they are still alive. And as I mentioned earlier, we know a lot more about the fatalities than we do about the non-fatal overdoses. And that is partly because our federal partners at the Centers for Disease Control and Prevention require states to gather very comprehensive data about overdose fatality cases, including toxicology results, hospital records, incarceration records, very detailed descriptions of the scene. And Marcy's going to talk about that a little bit later on. Marcy, I'll hand it over to you for the description of investigation of the fatal overdoses.
Okay. Hi, everybody. Thank you for coming. And before I start, I want to mention that even though we use one term to talk about this, overdose, these are incredibly complicated situations and each one is unique. We're going to try and talk about some of the population level similarities here, but I want to emphasize individual uniqueness. By Maine law, all of the deaths that are traumatic or unnatural or suspicious, we have mandatory reporting to the Office of State Medical Examiner. This includes all fatal overdoses. So we get all of those that people think are fatal overdoses coming to this office. And the purpose by law is to document who it was that died, where they died, and determine the cause and the manner of their death. So all suspected fatal overdoses are investigated. They get a physical examination. About 20% of the time they get an autopsy. Comprehensive toxicology testing is done, actually 2 tests, a screening test and a test that determines what level of the various drugs are present. And the range is very high in terms of the number of pharmaceuticals and illicit substances that are tested for. The medical records are reviewed on a person, and we build up a pretty thorough picture of what's going on, enough so that the pathologist can say what the cause of death is. Next slide. How do we track these overdoses in Maine? And we've been reporting on the fatal overdoses since 2002. I've been doing this supported by the Office of Chief Medical Examiner and the Office of Attorney General. And these result in annual reports. And then starting in 2016, we participated, as Rebecca mentioned, in the federal CDC's fatal overdose surveillance, collecting a lot of variables about the accidental overdoses, including the circumstances. And this goes into the federal public health surveillance system. The data are also available to us for summary. Starting in 2021, we've been providing the public monthly reports on fatal and non-fatal overdoses, including the circumstances, where they're distributed around the state by county, characteristics of the victims and so forth, supported by the Office of Behavioral Health and its grants and contracts, and the Office of Attorney General, and in collaboration, of course, with the Office of Chief Medical Examiner. Next slide. All of these monthly reports and the annual reports are posted on mainedrugdata.org. And this website has a lot more than just the overdose data. You can find public safety and public health data there, a very large range. So let's talk about the monthly overdose report that Gordon mentioned, comes out the month after an ending month. And so the previous month data is in it, and the year-to-date data is in it. And we will not have confirmed all the drug deaths by that moment. So we have a combination of suspected and confirmed drug deaths for the numbers. That means that the suspected drug death totals are not final. So we have mentioned the total of 716. That total is likely to change slightly during the months following. We have to wait for the toxicology reports to come in, sometimes as much as 8 weeks. And so we don't have a final number yet for 2022, but we think it will be right around 716. Next slide. They have been increasing, and they've been increasing everywhere. Maine isn't the only state that's been experiencing this kind of increase. Starting between 19 and 20, there was a 33% increase, and then a 25% increase the next year. And this year, as Gordon said, was 13.5 based on the estimated total for 2022. If we look, however, at a combination of the fatal and non-fatal overdoses, the increase is less. It's 4.5% between 2021 and 22. Next slide.
Take it from here, Marcy. Thank you.
Okay.
At least for now.
Yep.
Marcy, we are dynamically tag teaming this morning, so apologies for the coordination verbiage. So we wanted to give folks on the call just a brief history of how we got to this point. I'm sure most of you already know this information, but it's interesting to recount this history as someone who was in medical school at the time of all of this happening. So in 1996, OxyContin, which was one of the very first synthetic opiates produced and released to the public, was promulgated by Purdue Pharma. And most of you have probably heard at this point that Purdue Pharma at the time was really leaning heavily on false advertising around the potential addictive nature of this synthetic opiate. So the general message from the pharmaceutical company was, if a person is experiencing legitimate pain, they will not have a risk of addiction to this medication, and that OxyContin as a medication was less addictive than other opioid medications that were derived from the opium poppy, which is a plant that is grown. Of course, that was not the case. None of that was in fact true. And when I was in medical school, I very clearly recall talking about pain as the fifth vital sign. Physicians in training and physicians practicing medicine were encouraged to be far more responsive and let's say generous in their prescribing of this new OxyContin medication and other related medications that were released on the market, and really bring down a patient's pain to the greatest extent possible, which, as we all have experienced pain, know is nice, but also comes with risks. And those risks were very much downplayed as this fifth vital sign sort of ethos permeated the medical community. And it resulted in a massive increase in prescribing and what we now know to be excess prescribing of OxyContin and other synthetic opioids. They were pretty much given out for any type of medical procedure that might result in any kind of pain, including dental procedures, minor orthopedic procedures, etc. So by 2002, deaths in Maine had increased substantially, mostly due to misuse of prescription drugs at that time. 34 drug deaths were recorded in 1997 versus 165 by 2002. Just a little bit of background about fentanyl, because our current situation has evolved substantially from the time period 20 years ago when our overdoses were largely due to pharmaceutical substances and misuse of prescribed medications. We are now in a drug use ecosystem where fentanyl, a synthetic opioid, pervades pretty much every illicit substance that's available on the street. So fentanyl is a synthetic opioid similar to OxyContin, but it is largely manufactured in China illegally, of course, and shipped to Mexico, where drug cartels then distribute it across the southern border and up into the United States. Fentanyl is such a dangerous drug because it can easily be synthesized with common industrial chemicals, meaning it is much easier to produce fentanyl than heroin, for example, which relies on cultivation of the opium poppy. Fentanyl, because it is industrially synthesized, has a much higher purity and potency as opposed to the opium and heroin that's organically grown, which means much smaller amounts of fentanyl are needed to achieve the same opioid effect. And it's much easier to transport because it is so much smaller and far less of it is required to achieve the high that folks who use drugs are looking for. The proportion of deaths, overdose deaths due to fentanyl, has been increasing in Maine since roughly 2012. In 2020, about 67% of our overdose fatalities were due to fentanyl, either alone and in combination with other substances, versus the present 2022 estimate, which is around 79%. So this demonstrates that by far the majority of our overdose deaths are largely due to the fentanyl toxicity in the illicit drug supply. And again, these numbers do not represent deaths that are solely due to fentanyl, but most likely and far more often due to fentanyl in combination with other illicit or prescribed substances. But ultimately, because fentanyl is so potent and so toxic and very unpredictable in the illicit drug supply, it is typically the causative agent, the end cause of fatalities. As I mentioned just a moment ago, fentanyl is incredibly lethal. It is 25 times more potent than oxycodone. It is 50 to 100 times more potent than heroin. And in addition, it is very fast acting. Some people in the drug use community refer to it as instant death because it works so quickly to depress the respiratory drive that there is no time to really recognize as a person taking a substance that you're walking into an overdose. It 1 minute you are conscious, the next minute you are unconscious and not breathing. Fentanyl is also a frequent fentanyl contamination, I should say, is often unknown to the user. So a person may be a habitual user of cocaine or methamphetamine, or a habitual user of heroin, for example, purchase an illicit drug on the street, expecting to have their usual substance of choice and unknowingly have a fentanyl contamination in that substance. And even more dangerous than that is that the cartels and suppliers, distributors of fentanyl often mix fentanyl in with other illicit substances because it is so cheap and so easy to transport. And when that mixing occurs, it can be very uneven. So a batch of a substance may, sort of like a chocolate chip cookie, have concentrated bits of fentanyl in some parts of it and less concentrated bits of fentanyl in another. So some chocolate chips and some dough, as it were. And so a person who purchases, say, some illicitly manufactured pills on the street may take one pill, be totally fine, take another pill from the same batch, have more of the chocolate chip of the fentanyl in that pill, and experience a rapid and unexpected overdose. Fentanyl lethality is also multifactorial, as you can imagine, with such a potent and toxic substance. So because it is toxic in much smaller amounts than heroin or other organically derived opioids, it's very easy for the user to misjudge the dose. A single fentanyl dose the size of a grain of salt can be enough to kill a person, depending on the synthetic properties of the fentanyl. It's also, as I mentioned, extremely fast acting. So people can be unconscious before they're able to remove the needle that they were using to inject the drug. Fentanyl also has a unique characteristic known as wooden chest syndrome, which makes it very difficult for first responder clinicians, either EMS or emergency clinicians, to resuscitate the individual because of the rigidity of their chest wall and their airway. So yet again, increasing the risk for death during an overdose that is due to fentanyl. And as I mentioned previously, fentanyl is often also added or hidden to other illicitly manufactured substances, either as a cutting agent or to produce a unique high that would be appealing to the drug use community. Oops, excuse me, missed that slide too quickly. Another characteristic of the lethality of fentanyl, because it is so fast acting, individuals who are using drugs in isolation by themselves with no friends or family nearby, which is about 80% of our overdose fatalities in Maine, because it is so fast acting, these individuals can be dead within minutes and not be found by loved ones or friends until much later. And by then it's too late. So naloxone, if it is not readily available on the scene, and if there is not a person to administer it right at the time when the person who has ingested the fentanyl begins to show signs of depressed respiratory drive, the purple lips, no breathing action, it can be too late before EMS or law enforcement can arrive at the scene. And of course, the pandemic, the COVID-19 pandemic, has made the isolation situation worse because people were cut off from their support systems. They were afraid to be around others for risk of infection, and the loneliness and isolation pervaded the drug use community even more so than all of us who don't struggle with this addiction. So incredibly difficult circumstances. So as Marcy mentioned earlier, the drug overdose situation in Maine does mirror national trends. And across the board in the United States, drug deaths are being driven by fentanyl. This, again, similar to the situation in Maine, really began in 2012 when illicitly manufactured fentanyl first sort of arrived and began working its way from the East Coast and the Appalachian region over to the West Coast. The growth in fentanyl toxicity in the drug supply and resulting overdose deaths has been nearly exponential. And more recently, in the past few years, we've seen co-mingling of fentanyl with illicitly manufactured stimulants like cocaine and methamphetamine. And even more recently, unfortunately, we've begun to see co-mingling of fentanyl with a veterinary sedative called xylazine. And xylazine is not responsive to Narcan or naloxone. So a person may ingest fentanyl and also have a sort of bad on bad situation where their respiratory drive is also decreased by the xylazine sedative. And so they may not be able to be revived by the naloxone because they're still under the effects of the sedative. So this is making a bad situation worse, not to put too fine a point on it. As you can see from this slide, exactly what I was speaking about earlier, we really saw the sharp increase in overdose fatalities, very much co-occurring with the rise of fentanyl fatalities. So to the greatest extent, in terms of statistical analysis, we know that our ongoing struggle with the overdose epidemic is almost entirely due to fentanyl and the ready and cheap availability of fentanyl in our drug supply. It's an interesting note that we did see something of a dip in overdose fatalities in 2018. And researchers believe this is related to action taken by our federal government in relation to China, where China was temporarily cracking down on fentanyl manufacture by Chinese industrial plants. And so temporarily we had a reduction in both overdose deaths resulting from fentanyl, as well as fentanyl in the drug supply and fentanyl being seized by DEA. But unfortunately, that was short-lived, and relations with China took a turn in 2019. And unfortunately, the situation has not improved. So we are continuing to see readily available fentanyl being transitioned from China to Mexico and then across our southern border. As I was mentioning earlier, and just to put a finer point on it, our colleagues at the Maine Drug Enforcement Agency have seen a rapid uptick, almost an exponential increase in the amount of fentanyl that has been seized over the past 3 years or so. As you can see on the red line on this graph depicts the exponential rise in fentanyl seizures versus the heroin that is being seized almost down to zero. So really the ecosystem in terms of what drugs are being asked for by the drug use community or being made available by the cartels, actually to say it more accurately, is almost entirely fentanyl, and heroin is far less of a available drug than it was previously. And Marcy, I'm going to hand it over to you to talk about the suspected and confirmed overdose numbers over the course of the last year and a half.
Thank you. Yeah, this is a graph that shows the monthly numbers that we have. The blue color designates that we know that this is a drug death. The red color is a designation that it is suspected to be a drug death. And so you'll see that in the last few months. Over on the right there, we don't know about the majority of the cases that we suspect in December and a minority that we suspect for November and a few here and there for August and October. Next slide. Oh, actually, could you go back? I have one other comment about this. And that is, please look at how the lines go up and down. And the point here is that you won't see reliable trends from month to month. You're going to get a lot of random variation. So you really have to look, especially in a small population like Maine has, you really have to look over longer periods of time to be able to see something that's statistically meaningful. And in fact, when we look at all the years from 2002 up to the present, the only real big change was in 2018. The other changes are mostly, compared to the year before, not statistically different. And I know that sounds unlikely, but from a statistical point of view, we have a hard time talking about significance with small numbers like this. Next slide. So these are just the percentage of deaths that include these drugs as a cause of death. And I just want to draw your attention to the fact that fentanyl has gone up in the last year from 77% to 79%. Methamphetamine has gone up. Cocaine has gone up. And pharmaceutical opioids have gone up a little bit, although most of those are not prescribed, they're diverted drugs. Heroin, on the other hand, has gone down. And so you can see that there is a reshuffling, as you'll see in the graphs ahead. The methamphetamine and cocaine trends have been going up and up in the last several years. Next slide. And with the increasing amounts of those kinds of deaths, we have increasing polysubstance use. The average is 3 drugs listed on the death certificate. And I've seen as many as 6 or 7 listed. The medical examiner will list any drug that could be interacting in order to cause the death. So it may be that fentanyl is there, and we think fentanyl is very, very important, but there may be other drugs there that are also opioids or that also interact with opioids to depress the central nervous system, breathing, and heart rate. And so it's not a simple situation where there's one smoking gun. 43% of the deaths have either cocaine or methamphetamine or both. So we're almost up to half. And I mentioned already about the 20% pharmaceutical opioids not being prescribed. Xylazine, we're seeing 6% in 2022. We looked back, we had 1 case in 2019 that we discovered, but mostly it's been happening in the last year and a half. Next slide. So here are some of those co-intoxicants so that you can see their trend lines. And the blue line is fentanyl and heroin, which peaked in 2016 and has been declining ever since then. It's the blue line. Fentanyl mixed with cocaine has been rising ever since 2014. It goes up every year. Methamphetamine, which is the green line, is actually overtaking the cocaine. And it didn't used to be that way in Maine and really didn't start blasting off until about 2019 And you can see that green line going up then. And now it's above the red cocaine and fentanyl amount. Next slide. So we've got 716 cases that we've identified as suspected fatal overdoses. Looking at the naloxone administration among those cases, 11% of them have a witness or bystander administering naloxone at the scene. 14% have EMS administering naloxone at the scene, and 7% have police administering the naloxone. And I want to point out that a lot of times these overlap. So you can have all three administering naloxone. They don't necessarily, police and EMS don't necessarily get there at the same moment. And so whoever gets there first will probably start the naloxone administration. EMS was involved in 577 cases out of the 716. And among those EMS cases, 300, which is 52%, they arrived and the patient was already deceased. So they didn't try to resuscitate them because they were already clearly beyond resuscitation. In 33% of the EMS cases, resuscitation was attempted at the scene, but the patient did not survive. In 15% of the EMS cases, they did stay alive long enough to be transported to the emergency room, but then did not survive, either dying in the ambulance or at the emergency room. Next slide, please. Looking at this another way, here are some statistics about the non-fatal overdoses. And one of the things I want to point out here is just the massive impact that this has on our emergency personnel and responder organizations. Over 4,000 cases came to the emergency department, non-fatal cases. Most of them were transported by EMS from a scene. Over almost 3,000 cases, EMS successfully reversed the overdose, but the patient refused to be transported to the hospital. Among the people who do naloxone distribution, we had reports of community reversals over 2,000 in 2022. So 2,213 cases where the community member reversed the overdose. I want to point out here that, and that there are some more numbers that I have this morning on this one. The police successfully reversed the overdose in 73 cases without EMS being there. And they reversed the overdose in 462 cases when they were there with EMS. So the police are really bearing a large proportion of these overdose reversals. Next slide. This is another view of the overlap of these cases. And I want to say that for this pie chart, we deduplicated the cases. So for example, among the EMS cases, we have a certain number of the cases that were fatal. And we also have fatal cases among the police cases. And so we have taken those out. We are only counting the fatal overdoses once. And that's the 7% you see in the upper right. So this is looking at the number of people that had these experiences, but it doesn't reflect the complexity of all of the entities that might have been involved in the overdose. So the emergency department, for example, overlaps with EMS. In order to take out the overlap, we counted only EMS non-transported patients. So that's the lower left portion of the pie chart. And the community reversals, you can see, constituted about 22%. And the police reversals without EMS, and that's the only reason that's so tiny, is because we didn't want to count the EMS twice. And here are those numbers. So the fatal overdoses are 7%. The EMS non-transport folks are 27%. Community reversals, 22%. And this part of the law enforcement is 1%. And the emergency department is 43%. This is just one way to look at it in order to deduplicate as much as we can those kinds of cases. And that leaves 93% that were non-fatal. I just wanted to include a slide here about the critical role of community naloxone administration in all of this and what an important role they play. One needs an immediate response with fentanyl overdose. Seconds count. And so a community member with naloxone has a better chance of saving somebody than if you have to wait for the ambulance to come. And there is, of course, a possible delay in the emergency personnel arrival of either the ambulance or the police due to rural distances or workforce shortages. And so it's very important to have a variety of ways to get naloxone to these patients. Having the community members who can offer some support here does reduce pressure to some extent on emergency responders. Somebody in the Q&A asked about the demographic factors associated with the overdoses, and 73% in 2022 are male. And this is consistent with the rest of the country. We see this for the fatal overdoses pretty much everywhere. Less than 1% are under 18. It's a very rare case when we have someone under 18. Most of it is concentrated between 18 and 59. So 41% 18 to 39, 46% 40 to 59. And we even have 13% above the age of 60. Next slide, please. There are other demographic and social factors associated with fatal overdoses. The racial distribution is just about the same as it is in the census. So 93% are identifying as white, 2% as Black or African American, 2% as American Indian or Alaska Native. I didn't put that on the descriptor. 2% identify as another race or multiple races. The 8% report a military background of some kind. We are finding that 11% have transient housing, or they don't have a place to live right then. Up to 37% have a history of prior overdose, and some of these people have had many overdoses. And we have begun to look at how often people who have a fatal overdose, how often they have been seen in the hospital for any purpose within the prior month before their death. And it is 17% currently, which is quite high. It doesn't need to be that they came in for an overdose. They may have come in for wound care. They may have come in for a heart attack. We're counting any of those. It's an opportunity for intervention with patients who have multiple things going on in their lives.
Marcy, I can speak to this one.
Okay, great.
Thanks. So, and I really want to give Marcy the credit for orienting all of us through her long time and important work that overdose deaths do not represent the best measure of success for any overdose prevention or response program. And the reason I say that, and the reason that Marcy says that, is because the deaths represent a biased sample of all individuals who engage in substance use. The lethal drugs are, of course, overrepresented among overdose deaths because people who use club drugs, for example, are much less likely to experience an overdose fatality as opposed to people who are habitual opioid users. But that doesn't mean that there aren't those individuals who use club drugs out in the community. It's just that they don't die as often. So the deaths don't really give us the full picture of the ecosystem or the entire community of substance use, as it were. And of course, by extension, people who are more medically fragile, who are older, who have co-occurring conditions, are more likely to experience a death due to a substance intoxication than people who do not have those medical problems. So we tend to see the sicker and older individuals dying more so than the younger and healthier individuals. Although, of course, tragically, we see plenty of young individuals who do experience an overdose fatality, but yet a younger individual is more likely to survive because their physical characteristics make them more resilient to the toxicity as opposed to someone who has an underlying heart condition, diabetes, wounds that are septic, etc. And of course, we always want to make sure that people are aware that deaths due to overdose can be a result of multiple accidental factors. So in the past, I think there was a pervasive sort of concept that people who use drugs would sort of continue down a spiral of chaotic use until they eventually would expire due to overdose. And that's no longer really the most common picture because of the lethality of fentanyl in the drug supply, the unpredictable nature of fentanyl, the way it is incorporated in nearly every illicit substance that's available on the street today, means that far and away, individuals who may not be longtime drug users can still experience a fatal overdose without having that sort of pathway downward spiral that we might have in our minds as the classic picture of addiction and fatal overdose. And as we all know, fentanyl supply isn't within the scope of Maine's public health or public safety authority necessarily to control because it is a global international phenomenon. So China continues to not really crack down on fentanyl manufacturers within its borders. The US has a difficult time preventing fentanyl trafficking across the southern border. Mexico has a difficult time controlling its cartels. So it's a multifactorial international problem that our state struggles to really respond to, but we do the best that we can within the scope of what we're able to do at the state public health and public safety level. So if overdose deaths are not the best way to measure policy, what are the ways we should measure policy success? These are just a few of the ways that our office, the Office of Behavioral Health, Department of Health and Human Services, state government, the Margaret Chase Smith Policy Center, how we try to understand the impact that our programs and policies and investments of taxpayer dollars are performing in terms of the overdose crisis. So of course, the first thing, the most high profile thing is that we want to see a reduction in both non-fatal and fatal overdoses as a whole. For the same reasons that I just mentioned, fatal overdose reduction is, of course, the desired end goal, but we also want to see a reduction in the non-fatal overdoses because we can't predict, based on the chaotic nature of the drug supply, who will be the person who is next in line to experience an overdose fatality. We also would like to see an improved engagement with the folks who experience overdose and the emergency responder community. We are, through our, Good Samaritan law. I'm sorry, I temporarily forgot that phrase. The Good Samaritan law, which protects bystanders who call 911 in the case of a suspected overdose, is a massive step forward that our state has achieved thanks to good work by Gordon and others. But we would like to see folks feeling more confident and comfortable that they can call 911 in the case of an emergency, and that they can trust EMS clinicians with accurate information about the substances that have been taken, and agree to be transported to a hospital where we have more of an opportunity to offer harm reduction, peer support, and other supportive resources. We'd like to see increased post-overdose response capacity and engagement. We mean by that the options program, but we also mean expanding the options program, expanding the number of individuals that our options liaisons are able to reach, and expanding the connections to affected others, family members, friends, children of those individuals who are struggling with addiction, such that we can wrap support opportunities around them. We'd like to see expanded treatment capacity, which, as Gordon mentioned earlier, we are working very diligently on at DHHS. We'll be expanding the bed availability for inpatient treatment, and of course, also increasing the capacity of outpatient medications for opioid use disorder. We'd like to see expanded recovery support capacity. Gordon has been an incredible champion of expanding recovery supports across the state of Maine. And the more opportunity there is and the lower the barriers are for folks to engage in recovery supports, the greater chance there is that people will stay alive, stay in recovery, connect to their communities, and be able to maintain a healthy and long life. We'd also like to see increase in harm reduction capacity. This means not just naloxone distribution, but also other harm reduction activities that could include wound care for individuals experiencing substance use disorder related wounds. Particularly, I saw in the chat a question about the sores related to xylazine, which we can potentially get into, but other wounds associated with substance use or unstable housing. People often have foot ulcers from being outdoors, for example. So any kind of harm reduction activity that can help individuals stay healthy and alive until they're ready to engage in treatment is a step in the right direction. And of course, stigma is a continuing thorny problem that we hope to address in terms of reducing the community stigma and marginalization of individuals who struggle with substance use, as well as the stigma that applies by extension to their families and their loved ones, their affected others. We want to reduce that stigma so that people feel comfortable asking for help, being open and honest when they're struggling, and engaging in those relationships that can help them build that recovery capital and maintain a healthy life. And of course, primary prevention, which is the governor's very closely felt strategy that she mentioned during her recent speech. Primary prevention, intervening with children at the earliest opportunity to engage them and educate them and their parents and their teachers and their communities around the dangers of substance use and how to sort of address stigma and pressure by colleagues. Well, children don't have colleagues, but you know what I mean. Friends, peer pressure, as it were, in education and early intervention around young adults and youth who might begin using substances, and how to get in front of that before it becomes even more dangerous than it already is. Part of how our state is addressing these many ways of understanding our success is to really focus on what we understand to be a collective impact effort. So Gordon is the champion for pulling various stakeholders together to discuss how all of our efforts can sort of, by putting our efforts in one, not in one bucket, but piling our resources together for a single goal and sharing information, coordinating our efforts, really wrapping resources and programs and potential intervention points around individuals to try and provide them a safety net before they experience a negative outcome is incredibly important. And, you know, so many agencies have a stake in this game, have an interest in reducing substance use disorder and overdose in Maine. These are just a few of the many stakeholders who Gordon and I and Marcy and our various different committees and work on the day-to-day engage with to share information, share ideas, share resources, collaborate on programs such that we're really working together towards one shared goal as opposed to working in silos. And of course, with so many players, so many stakeholders, it can be difficult to coordinate, or I don't want to say wrangle cats because that's not exactly what's happening, but sometimes with that many moving pieces, it can be difficult to sort of keep everyone on the same page. And that's okay, because what we're really all aiming to do is we all have the same goal. We all want to make the overdose crisis better in our state. And so we will continue to work diligently to collaborate and coordinate around these important programs and this vitally important work, and continue to really try to bend the curve of overdose in our state. So ultimately, and this is my last slide, so we're almost done. Ultimately, you know, we continue to see these increasing overdose statistics, and that can get discouraging for everyone. But what we continue to do is approach every avenue, every potential, every promising intervention with an eye towards recovery is possible. And while fentanyl involvement in the drug supply is an incredibly thorny problem and explains much of the increase in overdose fatalities over the course of the last few years, there are other factors that we can influence at a state level. We can try to reach out to individuals who are using drugs alone and try to help provide peer support or intervention, education through multiple different avenues to try to help individuals not be so isolated. While we can't directly influence international drug trafficking, our Maine DEA and law enforcement agents here in Maine are working so hard to try to interdict as much of the drug supply as possible. And of course, you know, despite workforce challenges that limit our ability to increase treatment capacity and recovery capacity as quickly as we'd like, the state has made incredible strides forward with the recent Maine Care rate increases to more thoroughly compensate providers for these services, such that we can over time increase the workforce in our substance use provider organizations to better meet the demand in our communities. And thank you for your time. I'll hand it back to Gordon.
Well, I want to thank Rebecca and Dr. Sorg for their presentation. We've gone a little bit over. I really appreciate all the questions. I was keeping up with them for quite a while, but by the end, I could not. So we will, as I say, we will answer every question. We'll put those on the EdCare website. I'll make sure that EdCare sends you all the information on how to access the slides, how to access this recording if you want to share it with people, and how to access the list of answers to your questions. Again, I not only appreciate your interest in the issue, but I realize that many people participating in the webinar today are the people that really do the work in the communities, helping people to stay alive. So thank you for your support. We're going to make 2023 a better year for people, and I hope to see you with our federal officials on March 3rd for the next webinar. Thank you, and thanks to our presenters again.
Thank you.
All right, thank you guys. I'm sure we'll be in touch to finish getting all the questions answered, and I will be posting this recording by Monday. If you could send me a copy of your slides, please.
Yep, I'll send it right now, Lorena.
Okay.
Wait,
Oh, Marcy says wait.
let me just change the footers, which didn't get changed.
Oh yeah, no, that's fine. Send it to me Monday, or I'd like to post it Monday because there was so much interest. So, but send it to me Monday.
Yeah, all righty. I'll
Okay.
send it to you ASAP, actually. So,
Thank you so much. Appreciate it.
Sounds good. Thank
Everybody have a
you
good day and stay warm.
too. Bye. Good job, Marcy.
likewise.
We did it.
Thank you. I actually, that was nice. I didn't have to do a lot of those slides. And I thought
I
you did
think
a really good job. You really have a different perspective, and I think it was good to hear from you on these things.
Thank you. I am always happy to be your sidekick in this little show that we do. Thanks, Marcy. I'll see you later.
All right.